So welcome to today's session. Today we are looking at schizophrenia and we are focusing on the question from the June 2025 paper. So go straight to look at the question. The question reads, Peter Tosh, a male aged 24 with a known diagnosis of schizophrenia, is brought to the psychiatric emergency unit for allegedly threatening a neighbor with a knife. The family reports that Peter had stopped taking his medication 2 weeks prior and has become increasingly paranoid. The attending psychiatrist decides to admit him. Question A says, mention 5 psychiatric conditions that may present with violence. B, explain at least 4 types of schizophrenia. C, describe the management of Toshi during his violent state. D, outline 5 measures that you're going to use to prevent violence among psychiatric patients. So we'll go straight to question A. 5 psychiatric conditions where we may see violence. The first one is schizophrenia itself. Schizophrenia is a psychiatric condition where we usually see schizophrenia, just like the scenario has said, but this includes also other psychotic disorders. This is because of presence of positive symptoms like persecutory delusions, command hallucinations, apart from that, and other characteristics that we see, like of course aggressive behavior that we also see in schizophrenic patients. All this increases aggression in them and defensive violence. So the patient may become violent because they are harboring that aggressive behavior inside them. Other condition includes substance abuse. Patients who abuse substances, it could be alcohol intoxication, cocaine, and other drugs that are being abused by patients. All these can cause agitation in patient, paranoia, and aggression in them, inclusive of just withdrawal symptoms that we see from alcohol or even other sedative drugs. This increases irritability and violence behaviors. Bipolar mood disorders, and especially a patient who is in the manic state or having a manic episode. Such individuals experience extreme irritability. They may have grandiose behavior. Apart from that, also impulse behavior may be seen in them, which may increase poor judgment, and all these results in violent behaviors seen from bipolar patients, especially during the period that they are having manic episodes. Antisocial personality disorders, inclusive of also borderline personality disorder patients. Such individuals they use violence as an instrument to achieve a goal, or because of lack of empathy that they have. Because patients who have antisocial personality disorder, they have no empathy whatsoever. They disregard the feeling for others. So this increases violent behaviors in them. And of course, the last one is dementia, which is the neurocognitive disorder. Patients with dementia, especially those with the cause of Alzheimer's disease or frontotemporal lobe dementia, they highly become violent because of having confusion in them, fear, and misperception of care, because they will believe, for example, normal acts like wanting to bath them as an attack on them. So they will misinterpret all those things, which makes them increase aggressive behavior because of that impulse control that they have in them. When we talk about impulse control, it means that someone is reacting without thinking, and this is what happens in dementia patients. So these are the conditions that can increase violence, or where we can see violence behavior. Amongst the 4 types of schizophrenia, which question B requested, the first one is what we call as a simple schizophrenia, where we see its onset in adolescent stage, and common symptoms that we'll see indicating that this person has simple schizophrenia includes eccentric behavior, apathy, shallow affect, social withdrawal, lack of drive and initiative, and also declining in performance at work. However, delusions and hallucinations are rarely seen in this type of schizophrenia. And this is just the diagrammatic presentation of simple schizophrenic patients. The other type of schizophrenia we may see is what is known as hebephrenic schizophrenia, which is seen in the early 20s, of course, in adolescent stage. The patient appears to have silly and childish behaviors, and other characteristics that we may see is a flattened affect or incongruity. Delusions are rarely seen in hebephrenic schizophrenia, but hallucinations may still be seen in this particular patient. This is what we describe as hebephrenic behavior. Giggling, laughing, this is childish behavior. Someone may even laugh at during serious discussions like a funeral because they are having this type of schizophrenia. We also have what is known as catatonic schizophrenia. In catatonic schizophrenia, of course, it is seen in the later phases or age as compared to hebephrenic schizophrenia. And in catatonic schizophrenia, motor symptoms are the ones that are common, switching between excitement and stupor state. Hence, in catatonic schizophrenia, we see subtypes of catatonic schizophrenia, which includes the types like catatonic stupor. Just like the diagram that is shown previously, the patient is in catatonic stupor or mutism, and in this particular type, the patient fails to respond whatsoever to the environment or the people around it. Apart from that, catatonic negativism, the patient resist direction of physical attempt to move him or her, so they want to remain in that same fixed position where you have found them in, and that is a form of catatonic schizophrenia. We also see catatonic rigidity as a form of catatonic schizophrenia where the patient is physically rigid. And in catatonic posturing, the patient assumes bizarre postures. And of course, catatonic excitement, the patient is extremely active and excited. So when you talk about catatonic posturing, an example is this particular diagram. These are bizarre postures that we may easily see in a patient with catatonic posturing. So those are subtypes of catatonic schizophrenia. The other type of schizophrenia is paranoid schizophrenia. Like the scenario is telling us that the patient has paranoid schizophrenia, and this starts in the either late 30s or early 40s, of course. And this is the most stable form of schizophrenia, but the patient has paranoid delusions. Apart from that, the patient is very uncooperative and very difficult to deal with because they may be aggressive, angry, or fearful. Thought disorders and affective disorders, they happen in this particular patient, but they interchange. Hence, they are not consistent. A hallucination, especially auditory hallucination, are commonly seen. So someone with paranoid schizophrenia, they are suspecting that someone is after their life, someone is talking about them, someone is laughing them, someone wants to attack them. So they are always suspicious of someone or something. Hence, this is a good description that we may see in someone who's presenting with catatonic, in paranoid schizophrenia. The last type we can talk about is residue schizophrenia, and this is the type that happens after several years and repeated episodes of schizophrenia. The patient is seen to experience what is termed as a burnout. Apart from that, the patient may show characteristics like being down, social withdrawal, flat or inappropriate affect. They may have eccentric behavior, loosening of association, illogical thinking, and lack of interest. So all these are characteristics that we may see in residue schizophrenia. That is about the types of schizophrenia that we can talk about. Question C says, management of Mr. Toshi during especially throughout hospitalization, but the question said also focus on the aggressive state. Now, when we talk about management, of course, you need to start from investigations. Okay, so as usual, the medical management, you may need to start from the investigations. Talk about, of course, you talk about medical management and nursing management, and under medical management, this is where we deal with investigations and treatment. You can talk about probably maybe history of mental illness in the family. You can talk about doing physical examination, the patient may be presenting with positive symptoms like hallucinations and delusions. You can do maybe magnetic resonance imaging just to rule out brain lesions. You can do, of course, a mental state examination, which will help you classify the type of mental illness or type of schizophrenia. You can talk about doing maybe electroencephalogram. This will show high electrical discharge in the brain. So at least talk about 5 possible investigations that can be still carried out under medical management. Once you have 5 investigations, then talk about the treatment. And in terms of treatment, you can give drugs like copromazine, and as you mentioned, these drugs mention the dose, mode of action, and of course at least 2 side effects and 1 nursing implication. From there, you can also give drugs like Aten, and when you talk about Aten, you can give between 5 to 15 milligrams 8 hourly. Apart from that, you can give chlorpromazine between 100 to 1000 milligrams per day. This is dependent on the severity of the condition. And of course, talk about the mode of action, at least 2 side effects and 1 nursing implication. We can still give thyroidazine, and this one you give between 100 to 800 milligrams once per day. You can give still flufenazine decoyate, and this is common also known as Modicate. So flufenazine can still be given 25 milligrams IM every 2 to 4 weeks. Haloperidol can still be given 2.5 to 100 milligrams per day, and of course we can still give many others. Apart from medical treatment that you can mention on under medication, you can still talk about electroconvulsive therapy. This is still a mode of treatment that is given on treatment for schizophrenia where medical treatment has failed. Electroconvulsive therapy can still be indicated. From there, once you are done with the medical management, then you can talk about the nursing management. And in terms of the nursing management, talk about the safe environment. From there, discuss the nurse-patient relationship and put all these points that we have put under nurse-patient relationship. Talk about the rest and sleep, because the patient with schizophrenia will have difficulties sleeping. From there, talk about observations that you can carry out. Talk about cognitive therapy. Talk about psychological care or psychotherapy. Talk about hygiene. From there, talk about the nutrition and interventions that you do on nutrition. Talk about medication, of course. From there, talk about behavioral therapy, because the patient's behavior in schizophrenia is aggressive or violent, like the scenario has said. Hence, discuss or talk about points that will promote good behavior. From there, discuss aggressive management of aggression. The question said that the patient is in an aggressive state. Hence, a patient with schizophrenia will still manage the aggressive state. And finally, talk about the family therapy as well. So this is just the specific nursing care that we can give to a patient with schizophrenia. And of course, sometimes you may be asked for nursing care plan. These are the possible problems that you can apply in a nursing care plan. So be sure to try and go through how to write these problems in case you are asked to manage a patient using a nursing care plan. And these are problems that you can still apply in schizophrenia. And make sure you know the nursing care plan, because nursing care plans are still asked as part of management. And of course, the other problem we can have is risk for imbalanced nutrition, because patients with schizophrenia have difficulties with the nutrition or eating, rather, because they have all those suspicion. They will suspect the food is poisoned, hence they may not eat as required. Of course, the last question said 5 measures to prevent violence among psychiatric patients. The first measure is proactive risk assessment and communication. With this measure, you can routinely assess all the patients for non-risk factors, history of violence, non-adherence to medication, active substance use, and specific triggers, like our scenario where the patient has paranoia in them. So you can use a flagging system to alert all staff to potential risks, and you can hold regular team meetings to discuss the care plan of high-risk patients. So like this, you are managing patients based on the risk for aggression, and you can manage them adequately such that you prevent aggressive behavior, violence to even other patients. Effective therapeutic management, you need to create a structured, predictable, and calm ward environment with clear unit rules and consistent routines, because doing so will reduce anxiety and uncertainty for the patients. Apart from that, you can also provide mandatory and ongoing training for all the staff, and inclusive of what is known as de-escalation techniques, recognizing of early warning signs of agitation, and also safe physical restraints procedures. All this can reduce violence to other patients. Medication management, use of antipsychotic drugs can help manage aggressive behaviors amongst hospitalized patients. Environmental modification, the environment should not have should not be made in a manner that easily agitates the patient, should not have things that the patient can easily use to harm themselves. So let the environment not be able to stimulate the patient to want to harm themselves or even others. And of course, structured activities and psychoeducation. When you have routine, meaningful therapeutic activities, this reduces boredom and helps channel that behavior into positive activities rather than wanting to harm others. And of course, educating both the patient and their families about the illness is important. Of course, medication and adherence, and how to recognize and manage early signs of relapse. This way you can easily empower the patient and family to seek key partners in prevention of aggressive behavior or even reoccurrence of the condition itself. So basically, these are the ideas that we can use as we try to prevent violence amongst the psychiatric patients. So once we push in those measures, we can at least manage bad behaviors and just promote positive good behaviors. For today, that's all. Till next time, goodbye.